take our seats, please? Could we take our seats, please? We have a special treat this morning. We're opening up this session to a live webinar that CSG is transmitting, or whatever the right cyber word is, I don't know. But we're both here in person at the Medicaid Policy Academy, sponsored by the Council of State Governments, and we have a number of folks on the phone with us and the computers across the country, legislators and legislative staff people and other folks who've learned about this webinar, and we welcome those people to the broadcast. Our speaker this morning is Dr. Jeffrey Brenner from the Cooper University Healthcare and Urban Health Institute. He's from Camden, New Jersey. For the past 17 years, he has owned and operated a solo practice. As I read this long resume, I once had a speaker who said only his mother would sit and listen through all of that kind of an introduction. But he's a longtime family practice doctor in Camden. It sounds like he's done sort of cradle to grave kinds of care for folks. Grave is not a good word to use when we're talking about healthcare, but and in recent years has really worked around how do we provide better health care to folks, particularly in urban areas, particularly disadvantaged people. As a result of that, he's the winner of numerous awards, including what many folks call the MacArthur Genius Award, which is probably a good name. They have a much more official name, but it does go to genius type people. He's worked on helping systems across the country to do what he's done in Camden to better serve individuals. We heard a little earlier today in some of our sessions some allusions to what is healthcare besides traditional healthcare. We heard about buying air conditioners to prevent heat stroke and cardiac issues as a legitimate health expenditure. We heard talk about how do we get better at health outcomes and how does that relate to housing and other kinds of services. So I think in his talk he's going to touch on a number of those kinds of subjects, talk about how he's working both in Camden and around the country. And without further ado, I give you Dr. Jeffrey Brenner. Thank you very much for being with us. Appreciate it.
It's great fun to be here this morning. Thank you so much for the chance to come and speak with all of you. I'm a family doctor in Camden, New Jersey, one of the poorest cities in the country. It's directly across from Philadelphia. We really hope you'll schedule your next vacation to come and visit us in Camden. The city of Camden is only 9 square miles. It's 79,000 people, and because it's so poor, it's mostly publicly funded healthcare. And it's so small that it's a really good incubator and laboratory to begin to change how we deliver care. So I'm going to talk to you about what we've learned in doing that, and also what we've learned around the country as we've worked with other communities trying to tackle these issues. I'm a big believer, after doing this for a while, that the people's body, our legislators and legislatures across the country and state government, are the way that we're going to fix the American healthcare system. I don't believe that these are going to be administrative fixes. I think that you all play an incredibly important role to stand up and say, we've had enough. You know, this is a $2.8 trillion system that's out of control, and our families aren't getting our needs met, and we're not getting our needs met. So I assume if you're here today that you must be frustrated with the status quo and that you'd like to see change in healthcare, and that's what we're going to focus on today. While I work in the poorest city in America, today is not a story of poverty. Today is a story of an incredible system that we built. We've invested a lot of public money, starting with the Hill-Burton Act to build hospitals, moving into investments from the NIH to build a world-class research effort in America to cure disease, to CMS funding, to lots of state subsidies that come out of your states to build a world-class healthcare system. And we should be really proud of what we've created in America. We can separate Siamese twins, we can transplant hearts and lungs. The problem is we don't know when to stop. We just keep doing more and more and more and more, and the system has run away from itself. And even the system can't reel this back in. So at some point the public has got to stand up through you all and say we want change in the system. And I'm not here to tell you we need to ration care. We need to rationalize care. We need to rethink how we're spending money, which is going to create winners and losers. You know, there's no way that the largest sector in the economy, 18% of the economy, is going to shift without lots of fighting and lots of conflict going on. That's just part of how America works, political systems work, and what's going to need to happen going forward in this. So I'm going to start out talking about the work that we've been doing in the city of Camden, and then use that as a lens to look at some of the larger issues in healthcare. The other thing I want to caveat all this to say that there is not a vendor or consultant that is going to come in and fix your problems in your state. These are political human problems. These are not technical problems. So if you're waiting for someone to come and rescue you, the perfect consulting firm, the perfect vendor, the perfect IT tool, it doesn't exist. This is how people organize themselves and how they spend resources. So this is like a lot of the other problems you deal with in state government. The other thing is that we have an obsolete way of delivering services. So the basic infrastructure that was laid down by Medicaid is 50 years old, and not enough of that has changed. The basic architecture of healthcare and how healthcare is paid is very old. How your social services, behavioral health and addiction are structured is very old. The service delivery models are old. The way they're administered by state government is old. The contracts are old. All of that's going to have to shift. The work of your generation as state leaders is going to be tremendous transformation in these systems. It's going to hurt. It's going to be painful. There's a lot of learning that we've had in these systems about modern approaches to addiction, behavioral health, and healthcare that are not incorporated in any of the frontline service delivery, any of the contracts, and any of the ways these programs are delivered. So, you know, every generation gets a moment to rethink and reinvent and reshape services, and now your generation as leaders are going to be called upon to do that. When we're done, these services will look completely different. Money will move around in very different ways. The front line will look very different. The contracts, the people running the programs will look very different. So this is not incremental change. This is tremendous shifting that will have to occur within these systems. So what do these patients have in common? These are real people that we have had friends, colleagues, and programs interacting with all over the country. So a homeless patient in Trenton, New Jersey, with 450 visits in a single year, funded by all of you, the American taxpayer. So you should be outraged that we are wasting taxpayer dollars on a human being going 450 times in a year. And I'll bet every single one of your states, every single one of your communities in your states have stories just like that. We have found them all over the country. A dialysis patient in Allentown, Pennsylvania, living in a hospital with $1 million in inpatient costs over about a 6-month period, who had been fired by all the local dialyses and really needed behavioral health intervention. So we are foolish in how we're spending money. We're overspending in certain areas and underspending in other areas. A frequently hospitalized, wheelchair-bound patient living in a welfare motel with his 13-year-old daughter, getting repeatedly hospitalized for what are called decubitus infections, skin infections, because he couldn't get his wheelchair fixed and couldn't get a pad to pad his wheelchair. A middle-class patient in southeastern Pennsylvania with 147 CAT scans, enough CAT scans to increase their lifetime risk of cancer. A ventilator-assisted patient in Camden with $745,000 in charges and about $100,000 in payments over a 6-month period. You know, one of the best economic revival programs that Camden, New Jersey's ever had, your tax dollars going to hospitalize her over and over and over. And a dialysis patient, another one with $2 million in inpatient costs, found by a group of students that got the patient out of the hospital and got the patient re-engaged with dialysis. A group of students, med students, nursing students, and social work students. This stuff is not rocket science. It's unacceptable behavior going on within your states and within the systems in your states. So this is a story of outliers. This is a story of really all the people that government touches. Government doesn't usually touch average people. Government programs touch outliers. These are people in a data sense. If you make a bell curve of everyone in the state of New Jersey who went to the hospital in a single year, there's going to be a group of outliers that went there 30, 40, 50, 100, 200, 400 times. That's the long tail of data. And it turns out when you get out into that long tail of data, it's a messy part of the data set that no one wants to deal with. So most large programs where you spend lots and lots of money deliver average care to the average person. But the minute you start to get more complicated, the programs just don't know what to do with you. They don't know how to deal with you. And as a result, you hit every state system. You go to jail, then you end up in the mental health system, then you end up in the hospital. You end up bouncing through all of these different systems, driving lots and lots of costs. So the problem with our large systems is that they're not very good at dealing with outliers. So if you're a kid in a classroom with a differential learning style, the teacher, you may be having challenges with discipline. There'll be one kid in each classroom. The teacher just doesn't know what to do with them. There'll be a couple of families in every school where, because of the family structure, they're having lots of challenges. School doesn't know what to do with them. That school's having a problem pivoting to the needs of outliers. We don't have a language for this in government. We don't have a language for this even in data. And in fact, in epi and biostats, they actually want to cut the long tail off because it messes up your data analysis. So, in insurance, those are just like accepted losses. We just accept every year we're going to lose a certain amount of money on the outliers, and we ignore them essentially. So who are patients with superutilization? So the term superutilization is a term we've coined to talk about these outliers in healthcare and in other systems as well. Are they all homeless? Are they all mentally ill? Are they all addicted? Are they all with complex comorbidities, multiple illnesses together? Do they have medication confusion, transportation barriers? The answer is really complicated because not all mentally ill patients are high utilizers of healthcare, and not all high utilizers of healthcare are mentally ill. These are risk factors, and the more and more of them you have, the system starts to break down because the system is not built to deal with complexity. So this is a CAT scan of a middle-class woman with a master's degree. So she could be a family member, she could be you all. To make the point that this is not a poverty problem, this is a healthcare delivery problem. It's being exacerbated in poor communities. So this woman went to get services in a highly integrated 5-hospital system, completely connected with Epic electronic health records, where you just click a tab and all of the emergency room doctors in all 5 hospitals can see all of the records on this patient. So this is supposed to be nirvana, like when your folks come and lobby you and they say, we need integrated healthcare, you just need to give us more money to integrate healthcare, and then we need to connect it all, and there'll be this healthcare nirvana with perfect exchange of data. So this is it. And this patient had 102 emergency room visits, 54 admissions, 147 CAT scans, and 73 CAT scans of the head. That's an abnormal CAT scan. You don't need 73 of them to figure it out over the course of just a couple of years. This could be you. This could be your family members. This is a problem that's going to have to be fixed at the legislature. This is going on everywhere in every community all the time. It's occurring to you, many of your constituents as well. This patient was found by a group of family medicine residents who were frustrated, and they got a list of every patient who'd had admissions and rank ordered them and went and met one of the most extreme patients and found her. She ended up having severe anxiety, was why she was going to the emergency room, got her into therapy, and she stopped going. So a much better use of our money. Another example is a 55-year-old man admitted for a stomach bleed and shortness of breath. This patient is a dual eligible. The patient has Medicaid, which is the healthcare program for the poor, and Medicare, which is the healthcare program for the elderly. If you are disabled, older, and didn't have a lot of income in life, you can end up on both programs. That subset is called dual eligibles. They're the most expensive group in America. So this patient lives alone in a high-rise apartment, in 6 months had 9 emergency room visits and 6 inpatient visits, and is on 12 medications a day. These are all the services touching this patient. Can you imagine how overwhelming it would be to be this person? We picked up the patient in hospital number 1, went right to the bedside and got to know him. We followed him out to a subacute rehab. He went back to hospital number 2, got readmitted. We needed to coordinate home nursing, home PT and OT, transport, meals. durable medical goods, dialysis, nephrology. Primary care provider had to coordinate ophthalmology, pain management, GI, cardiology, urology, oncology, and surgery. Is it any wonder that we have a $2.8 trillion healthcare system? The most expensive healthcare system in the world. So, we don't need to ration care. We just need to get organized. This is not rocket science. This is just extremely disorganized care where people get lost in the system. My favorite, I have stacks and stacks and stacks of pictures of piles of medication in people's homes. This is access, right? This is like access, to medication. Extraordinary access to more and more and more and more medication, and bottles of medication. People save every medicine bottle you've ever prescribed them for 10, 15, 20 years. Piled it up on every drawer, every cabinet. Our first job is just literally to open all the cabinets and pull all the bottles out, put them all on the table, and then convince people to let us get rid of them. And then figure out how to get that giant list down to a more normal list that people can actually take. Because in many cases, they're not even taking all this stuff. We have a bag that's worth $50,000 of medication that's been started and stopped by all the local hospitals on a single person. That's how confusing all this stuff gets. So this is the patient in the middle. His name's Glenn. On the left is his primary care doc who works at an FQHC. In the middle is Corinne, who is an AmeriCorps volunteer, a young woman just out of college, who spent a year with us as a health coach. Lots and lots of training. She spent a ton of time with Glenn helping him navigate through the system. And on the right is Jason Torrey, who's a nurse. We don't need more licensed people to do the work. We need lots and lots and lots of navigators, coaches, community health workers. They're called all kinds of things, but they need to be supported, backed up, trained by qualified social workers and nurses and behavioral health staff. This is another patient, 52-year-old woman, Spanish-speaking, admitted for shortness of breath, lives with her family. In 6 months, had 6 inpatient visits. She lives on a breathing machine, a ventilator, and has a hole in her neck, a tracheostomy. She has severe lung disease. This is a visualization of her healthcare utilization. So this is very simple in Excel. Time along the bottom, and the pink side was 1 year pre-enrollment. That's before a program picked her up. Blue side is post-enrollment. Each of the red lines is a visit to the hospital, and the blue line is an emergency room visit. So the way you read this is in May 2011, she had a 6-day stay at the hospital, got out, was back a week later for a 4-day stay, got out for a couple of days, was back later for a 7-day stay, stayed out for a little bit, back for a 10-day stay, 11-day stay, on and on. $745,000 in bills sent out, $95,000 in payments from all of you back to the hospitals, and 55 days in the hospital and 1 ED visit. And she stopped going. So let me introduce you to her. Her name is Lillian Perez. We worked with her for about 90 days. Ashwin on the left was another AmeriCorps volunteer. He's currently in med school. And Corinne on the right again, and Jason Torrey in the middle. So if you can imagine having a family member living on a breathing machine, how terrifying that would be. So the trick for her was to have a whole lot of training for the family about how to manage the ventilator, and then to have the pulmonologist and primary care doctor really work together as a team to make sure that everyone was on the same page about how to manage her care. She stopped going. So, we have large, unaccountable, expensive systems paying for care in the wrong way with lots of profits being made in the current system. And, getting to this is not a simple change. This is a dramatic change in how we think about care, how we train providers, how we pay for care, how we move data around, a whole variety of things in order to start to achieve this. So I run a 13-year-old nonprofit that's called the Camden Coalition of Healthcare Providers. It was started in the community by the providers. So it was a group of family docs in the community that were fed up, came together, and began to put this together. We're now an $8 million organization. We have the hospitals on our board, highly competitive hospitals that don't like one another. We've got local nursing homes, FQHCs, the whole alphabet soup, behavioral health, addiction, social services, playing nice, sharing data, and working to deliver better care at lower cost. It's been a painstaking, painful, difficult process to pull them all together, to have them share data and have them, even begin to work together in this work. Our vision is to make the city of Camden the first city in the country to bend the cost curve and improve quality. And our belief is you have to have a local integrator. So there has to be some entity knocking heads and bringing people together, because healthcare is a local industry. It's how does the behavioral health folks work with the addiction folks, work with the nursing home, work with the 3 hospitals, so that people aren't bouncing all over the place. You have to have a local integrator to get people to play nice, to share data, to begin to solve these problems. The more expensive you are, the less loyal you are to any particular institution, and the more likely you are to bounce from ER to ER and hospital to hospital. So someone's got to bring them all together and change the conversation. You can't do that from the state level. You've got to have local partners that are beginning shifting that ecosystem. So the major reforms going on around the country right now in Medicaid are regionalization of services. So Oregon's model is essentially pulling regions together and saying, you better play nice, here's your global budget. Colorado's model, regional budgets, regional integrators, sharing of data, knocking heads, saying you got to play nice. So you're seeing more and more of this evolve around the country. We're going to have some regional thinking going on region by region. So the coalition is not unusual. There are many organizations around the country doing the same stuff that we do. And what's unusual is we're in a very small place, it's a very poor place, and we've collected them all under one roof. So we run the Regional Health Information Exchange. We've got real-time data flowing in of hospitalization, demographics, labs, radiology, and discharge summaries from 5 local hospitals. We have about 20 people in the field chasing the complex, high-cost patients around. We've got a whole team inside of the primary care offices helping them redesign and rethink how they serve these patients. We have primary care providers, highly trained folks, running from room to room to room in meaningful increments of 10-minute visits that add up to nothing and fail the most complex and difficult patients. We're doing a lot of advocacy change, as I said earlier. None of this is going to change until some of the rules start to change. There's a lot of obsolete rules. We've had to retrain a lot of staff. The staff that come out from licensed programs don't have the mix of skill sets to do this work, and a fair amount of data and data research that I'll show you. All of this work began as a med student summer project where we got a hold of the claims data, the billing data from Cooper, Lords, and Virtua for Camden residents, combined it together into one data set, and for 10 years we collected the name, address, date of birth, date of admission, charges, receipts, all of the billing data from 3 local hospitals for the entire city of Camden on 2 $50 hard drives with open source encryption, Microsoft Access, and a series of students and young people working with the data. So this is not big data. Like, for most of the years, it never cost us more than $25,000 a year. So what we learned from the data is that half the population uses an emergency room or hospital in 1 year. We learned that in Camden, someone went 113 times in 1 year, 324 times in 5 years. We learned that all of you have funded Camden's hospitals for caring for Camden's residents, a city of 79,000 people, $108 million a year. The most expensive patient was $3.5 million in receipts. 30% of the payments are for 1% of the patients. 80% of the payments to the hospitals are 13% of the patients, and 90% of the payments are 20% of the patients. The number one reason in a single year to go to the emergency room in Camden was head colds. There were 4,000 people going for 4,800 times with $1,400,000 in payments to the hospitals just for treating head colds. Number 2 is sprains and strains, contusions, lumps and bumps, abdominal pain, skin infections, urinary tract infections, on and on. I mean, this is a completely unaccountable system. You know, the common thing I hear people say is, oh, the patients like to be in the emergency room. I've worked with poor people for 17 years of my life. I've never met a poor mother with 3 kids who like to sit in the Camden emergency rooms. I have a few people that I will gladly introduce you to who are homeless, living in tents, and when it rains, they really do like to go to the emergency room. But folks don't want to bring their kids for head colds because they can't get appointments. If you call right now your own primary care provider, I challenge you to get in today. So they're having an access problem. This is about choice architecture. And this is about what happens when you pay too much for one set of services. If you pay too much for emergency room care, you'll get too much of it. You pay too much for hospital care, you'll get too much of it. You don't pay enough for primary care, it'll fall apart, it'll go away, and you won't get access for it. This is just basic law of economics. In my time in Camden, my office is currently boarded up and closed. So I'm a zealot out there trying to figure out how to take care of poor people, and I can't do it. My medical home is currently boarded up and closed because my payment rates kept falling. By the time I closed, I was getting $19 to $35 a visit. In the time I've been in Camden, we've tripled the size of the emergency rooms. We have built new wings on hospitals, hired more specialists, bought robots to operate on people, and care of the poor is falling apart, and people are going for head colds. For the $1.4 million we're spending on head colds, you could open 4 primary care offices and have them up and running. It's only a city of 79,000 people. That would increase the primary care supply by 25%, just moving the payment for head colds around. So I promise you, I've looked at data in many communities across the country. We have data from the state of Maine and rural state. We've got middle and upper class communities. I've got employer data sets. Same pattern everywhere we've looked at. Wasted money and money being spent in the wrong places. Too much money spent on the wrong things, not enough money spent on the right things. This is a map of the city of Camden, looking at where do people live, where do the most expensive patients in Camden live. So 5 years of claims data from Cooper, Lords, and Virtua, small city, 9 square miles, and the red areas on the map are 6% of the city blocks, 10% of the landmass, 18% of the patients, 27% of the visits, and 37% of the payments to the hospitals. So it turns out all over America, in rural states, urban states, suburban states, expensive people are all collected up into buildings. And they're going back over and over and over and over. There's literally like a line of ambulances sometimes picking up these folks, taking them over for a stay at the inn, and then bringing them back. So these 2 buildings are beautiful buildings with great management. Building at the top had 600 patients that are dual eligibles who had $12 million in payments to go back over and over. Building at the bottom had 300 patients with $15 million in receipts. It's a subacute rehab and nursing home. So I want to talk briefly about the model that we're using and how the model works. We look at the data every day of who's been admitted in real time coming through the HIE. So think about what's going on here. The business intelligence of the local hospitals is coming to us in real time. Then I'm sending my staff over to the hospital to get rid of their customers and keep them out and keep them from coming back. So that's how hard this work is. So tremendous amounts of data sharing going on. We go right to the bedside. I've got full-time staff in the hospital enrolling patients. We go through a whole process that's behavioral health driven to help patients develop their own care plans. Where are you in your life? Are you happy in your life? How do you want your life to change? This is not take your medicine, be compliant, do what I tell you to do, go see the doctor, take your pill, exercise. This is where are you in your life? This is your 5th time going to the hospital. Do you feel good? Are you happy with where you are right now? What do you want to change? You want to see your daughter graduate from high school? It doesn't look like that's going to happen lying here in a hospital bed. What are you going to have to change for that to happen? So this is using modern ideas out of behavioral health pulled over into medical care. Here's what doctors do. They go to the bedside of one of these patients and say, Mrs. Rodriguez, how many times have we told you you've got to take your medicine, go and see your doctor? If you don't start doing that, we're going to cut your legs off. And then they go storming out of the room. That's our modern training for our doctors and how to change behavior. So we go right to the home within 72 hours. You got to pull all the drawers open. You got to get to know people, get to engage their family. We do this across 15 different domains. So these are the extreme patients. These patients cost $50,000, $75,000, $100,000, sit in 6 months or a year. Working on addiction, working on housing issues. If they're homeless, helping them move in. If they've got outstanding court issues, resolving them. We either do this or they're going to live in the hospital. So, the issue of personal responsibility and all these things, they're going to be in the hospital or they're not going to be in the hospital. There are a set of things we're going to need to do to straighten this out. Lots of sorting out meds. We go with them to their primary care and specialty appointments for about 90 days, and we're teaching them how to talk to doctors. And we're teaching the doctors how to talk to the patients. We're helping them prep ahead of time and coaching them. You're going to be going in, the doctor's going to be in a rush. What do you think you would really want to bring up? Let's make a list, let's write it all down. And then afterwards, how did that go? How did that make you feel? How could that visit have gone better for you next time? Helping people navigate all the services. Lots of partners that you end up having to figure out how to get to work together. We do a monthly meeting with all the partners where we do a case-based discussion. where we talk about real cases of real people who are anonymous, who are hitting every service. So all of these folks are in that room talking about real people. And the stories are stories of failure. This is root cause analysis of service delivery failure, where pretty quickly the story points out where all the cracks are. Lots of tracking. We collect about 400 different variables in real time on everyone, and then graduating. Lots of dashboarding and scorecarding. This work is very hard to manage. It's very hard to supervise. It's very hard to train the right people to do the work. It's all part of a randomized controlled trial now, so there's not enough research base in this work. Very important to begin building out the research base. So let me stop there. I think that's a great spot to stop, and why don't we have some discussion?
Thank you. My name is May Flexer. I'm a state senator from Connecticut, and I've read about your amazing work before. And I know that as state legislators, we have a unique ability to convene people, to bring people to the table, to have a discussion, and talk about a model like what you've done in New Jersey. Can you give us some advice on how we could do that and who we should have at that table?
That's such a great question. There are two things I'd recommend. One is to let stories lead the change. So, this is really just a sophisticated framework around change management, and everyone's going to be defensive, right? I mean, this is about everyone in the current system doing what they know how to do, and everyone wakes up in the morning feeling like they're a good person working hard. Like, no one wants to believe they have to do something different. That's just human nature. So, in these cases, the actual patient stories are the perfect. You don't need to say the system's failing. Just put the story in the middle of the table. So, if you called up one of your local, if you called up the Medicaid agency, the head of Medicaid, and said, I want the list of the top 10 people in Medicaid that go over and over and over, not by cost, but by utilization. And then I want to go out and meet number 1, number 2, and number 3. Or I want one of your staff to go knock on the door and find out what the hell's going on. Have you ever met any of these people? And I'm not saying you, I'm saying rhetorically, like, they're delivering all these services. Have anyone from Medicaid ever gone out and meet your 10 highest utilizers? So what you'll find out when you go and hear the story is, I guarantee 8 of the 10 are complete fiascos. It's just it's like the bridge falling down. So those stories are really powerful. Bring the patient. Let the patient come and testify. I mean, we have had testimonials from patients all over the country. You wouldn't believe the stuff that happens to them. Some of them are very eloquent spokespeople for what's going on. So I would do the N of 1 patient stories, which is root cause analysis, and then I'd bring the data. Just put up the list of what did the top 10 people cost, the top 100, how many times did they go back? And then let all of your administrators and all of the lobbyists and stakeholders tell you why. Just let them talk. Say, oh, it's the patient. Those patients won't do what we tell them to do. Or hospitals will say it's the transportation. Transportation will say it's the doctors. The doctors will say it's the nursing homes. Everyone's going to tell you why it's someone else's problem. Just let it all play out. I mean, it's beautiful to watch. It plays out exactly the same way everywhere we've seen, And the stories will lead you to the beginning of the solution. There's a model called Lean Startup, and there's a wonderful Harvard Business Review. There's a great book on it. And Lean Startup says, if you set out right now to build a state plan to fix this, you would fail, because this is too complicated. It's a very thorny, wicked problem with too many stakeholders. So instead, you build perfect care for one person. So if you took the highest utilizer in the state, and you as a legislator banged your fist on the table and said, this is unacceptable, I want to know by next month what you've done to solve this. I want you to go out and meet this person, and I want to know what you've done to fix it. I guarantee your state officials could fix it for one person. And the learning is very powerful, because typically what's going on is your addiction program has very specific criteria that doesn't fit that person. Your behavioral health program says, no, they're not eligible. Your housing program says, no, they have to be a schizophrenic in the first year of their diagnosis between the ages of 20 and 21, male with who's a Scorpio, and we can get into our program. So you find out that all the crazy rules that all the state programs have made just leaves all these people out, and everyone's just hands are tied in knots. So that would be my recommendation. Yeah, sure. And through We'll send out the connection about Lean Startup as well.
I am a VP State Senator from Nebraska, and I've sort of been the negative Ned during much of this session because I am absolutely convinced that you have to look at the cost structure first, and I applaud you for that. I think that you're turning this thing upside down. You're going after and moving it away from a sickness industry to a wellness side, and so I simply wanted to be a positive reinforcement for what you're doing and what others can and should do. Thank you.
Great, thank you. Thank you very much. We're definitely have to tackle the economics of this and shift the business model if we're going to make any headway on all this. Okay. Any other thoughts or questions?
Yeah. Tina Liebling from Minnesota's House of Representatives. First of all, thank you. This is really exciting. I also knew a little bit about your work. But my question is, are there data privacy issues that get in the way of cracking this? Because I know that comes up a lot, and some of what I hear you say, I'm thinking, uh-oh, I wonder if we could do that because of that.
I promise you I haven't broken any federal or state laws in anything I've done today. So it's interesting. If you read HIPAA, HIPAA's very clear that you can do data sharing and data analysis for quality improvement purposes, for clinical purposes, for research, a whole variety of purposes. So all of the work I'm describing very quickly clearly falls into what HIPAA allows, and most state laws allow as well. So there's nothing about using data for strategic planning and for understanding where service delivery failures are occurring that's against any rules at all. Instead, the real impediment to this is a cultural impediment. So hospitals don't want to let their business intelligence out the door. And we've interacted with a lot of states around the country, and all of the departments and all the divisions within departments are careful guardians of their data because data is power, and within government, no one wants to lose their power. And you can't connect any of the data sets across government. And every time they do that, it's always like an ad hoc, one time only, everyone's making it up. There's no clear channels or lanes for any of this stuff. So everyone is nervous, they want to shut it down, they see risk when this happens, and they don't want transparency, frankly. Because look what happens when you connect all the data. Like, none of this is rocket science. As I said, you could do this tomorrow in your own states and in your own state government, but it doesn't tell a very good story. So the real impediments to this are cultural impediments and embarrassment impediments. So as a legislature, I promise you we're not breaking laws. In Minnesota, I'm going to give you a huge compliment. What's going on in Hennepin County is further ahead than what we're doing in Camden. And it's because of the alignment between the county and the providers and just a unique array of things going on. So you have some really special stuff going on that everyone around the country is watching and learning from. Also, the way the state has dealt with some of the data sharing for healthcare has been very advanced around quality data. So, I think you guys have made already tremendous strides in some of these areas. Any other thoughts and questions?
Good morning, Garen Tar from Alaska. I'm just wondering, do you see your model is fairly labor intensive in terms of having those people go to the home and be with them on those visits, and do you see sort of things evolving or how do you see things evolving over the long term as you move, I would think towards more preventative care options and sort of behavioral changes and what that means for the next generation?
Such a good question. Thank you for asking that. Let me shift to talking about the ACE study. Has anyone heard of the ACE study, Adverse Childhood Experience Study? Great. I think this is the most important thing I'll leave behind for you. There was a study done about 15 years ago at a huge health system in California called Kaiser Permanente, and a physician named Dr. Felitti sent out a survey to 15,000 middle-class Caucasian patients. 70% of them returned the survey, and he asked them 10 questions about the horrible things that happened to them in childhood. Death of a parent, physical abuse, sexual abuse, a whole variety of really awful things. Then 70% of them returned it. And that's an amazing fact. Can you imagine getting a survey like that and actually filling it out and returning it? Normal survey response rates are in the teens. So there's something really interesting about 70% of people returning the survey, and they gave them permission to connect it to their medical records. And to this date, the best predictor we've ever found for healthcare spending, healthcare utilization, smoking rates, obesity rates, substance abuse, alcohol, poorly controlled chronic illness, out-of-wedlock teen birth, probably incarceration, and chronic homelessness is the number of really awful things that happen to you as a kid. So it's turning out the biology of this is being much better understood. And if you have terrible things happen to you as a kid, your brain gets literally rewired to be wary and suspicious of everyone. And your stress responses are really cranked up. You have a hard time understanding other people. Social cues always seem threatening. You overreact. You walk on a hair trigger. We all know people like this in the workplace or in traffic, right? So you think everyone's out to get you because when you were a kid, no one took care of you. It turns out it's really hard to have a stable job, stable marriage. It's hard to raise your own kids. And when you get to 50 and 60, you start falling apart. You die 20 years before the rest of us. Or you end up in all these state systems. All your state systems are just dealing with the same group of kids who had really crappy stuff happen to them. Some are going off to jail. Some are getting admitted to the hospital over and over. Some are stuck over in the behavioral health side. They're ending up, in foster care, all these different systems. So this is the biology, sociology, psychology of what's going on here. And our service delivery models are ancient. They don't work for these folks. So there are much more modern models coming out that are called trauma-informed care, harm reduction, that can begin to work with these folks and make profound differences in their lives. They can begin to repair some of the damage and begin to move forward and do very different things in their life. But this dichotomy we've got of individual responsibility versus social responsibility, it's the wrong dichotomy. Instead of saying what's the matter with you, we need to ask what happened to you. That doesn't mean the state coffers just pop open and we pour money out. That's not what I'm saying at all. What we do is take the existing money we're spending and buy the right stuff so that we're actually spending the money well and buying evidence-based services to change lives. I think no matter where you are on the political spectrum, if you're spending state money, you want to change lives. Like, no one wants to, I don't think, in the legislature, really waste precious public dollars. We're in an age of austerity that's not going to go away. So we're going to have to really rethink these basic assumptions. Yeah.
I'm Keith Frederick from Missouri. My background is an orthopedic surgeon. I assume when your practice was up and running all those years that you were actively trying to address all these difficulties, but then your practice became non-sustainable. And I wonder about the practices that you're working with now that are trying to work through what keeps them from becoming non-sustainable. That's one part of it. And then the health coaches. It seems that the health coaches, and I assume that's the 20 people you have that are tracking down the high utilizers. But first, what is their training and background? And is there an opportunity to embed them more into the practices so that they don't view them as an external force coming at them, but they're within the practice?
Absolutely. Really great questions. Unfortunately, the practices are fading. The providers are getting older, they're closing down. I think the only thing we'll have left in poor communities and maybe rural communities are going to be institutional providers, FQHCs, hospital-based providers. So we're rapidly seeing that. I think we're going to see that all over the country. And if you would ask me 10 years ago, I would have been outraged about that. I think the modern expectations of what a primary care office should be doing are such that a mom and pop operation can't deliver that. The requirements around electronic health records, PQRI, data collection, and the team-based structures that we really need to do this aren't going to work in mom and pop settings. We're going to need more sophisticated organizations to do this. It pains me to say that. I had a beautiful 3-exam room office that I loved. I loved being my own boss, but honestly, I was falling short every day. And I was falling short because I didn't have the fixed cost and the infrastructure to do these more advanced models. Eventually we're going to have behavioralists working right together with primary care folks to be able to address the behavioral health issues. That takes a far more sophisticated infrastructure to be able to do this. With regards to the training for our team, we use a mix of social workers, nurses, LPNs, medical assistants that are trained as community health workers. All of them have to be retrained. None of them come out of school with the right array of skills. And it's a mix of harm reduction, trauma-informed care, motivational interviewing, a lot of behavioral health and addiction skills in order to sort of reframe. I'll give you an example. Lots of people want to rescue poor people. So you'll hire the warmest and fuzziest young person who goes out and will make appointments for patients. And that does the patient no good because in 90 days we're not going to be there. So instead you should spend twice as long teaching the patient how to make the appointment. So it actually takes a lot of self-discipline, not to just keep doing and doing and doing for people. So a tremendous amount of training and thinking about how to set up a structure to do that. Then the managers for these have to do a very different style of management because the stress of the frontline staff of working with these folks is very intense. So you need managers that can both help them structure their work as well as handle all the emotional content of what they're dealing with. So the managers need to be differentially trained as well. We had to home grow a lot of our managers because there aren't lots of people who know how to manage this work. Our model is modeled on something called PACE and ACT, which are models that are all over the country. They're very intense models for high-risk patients that are evidence-based. So hiding in your states are very interesting models that have spread all over the country that are intensive models for subsets of high-risk patients. So the idea that you need to deliver more resources to unique subsets of people is not a new idea in healthcare. It's been around a long time. What we're not doing a good job of is sorting people and then attaching the right price and the right service package to each of those levels of risk. So, way down the road, what should really happen is you take the entire population, you have some kind of an algorithm where are they jail involved, are they DIFUS involved, are they behavioral health and addiction involved, medically involved, which part of state government is touching them, what's their risk profile. You would set a price out. You would say this is a person who's going to need $1,000 per month of services for a year, and after that they're going to need $500 worth of services. And then an integrated package of services are delivered for them. And if they're addicted with drug court involvement, parole, and a doctor, you're going to have slightly different models for each of these subsets. And we don't have the pricing framework. We don't have the word for this is segmentation. So we don't properly segment, and then we don't have focused factory models, highly structured, well-organized delivery models for each of those segments. And then we don't have the pricing built out for the segments. Instead, we have these very siloed things where you can't move back and forth between any of the programs.
Hi, Joni Jenkins from Kentucky. I have two questions. One is, after 90 days, do you go back and track these folks like a year later or 2 years later?
Yeah, what's interesting is because of the health information exchange, we know every day who's been readmitted. So for our randomized controlled trial, it's very interesting. I know every day how we're doing. So it's really a powerful tool because the readmissions you know about right away and can do root cause on them as well. Once again, it's very rare to have that kind of data coming in, streaming in like that, but very powerful data. It's another example where, state government sometimes have to stand in the middle of a mess and force all the players to play a certain way. HIEs around the country have floundered in some cases. The most important data element that an HIE can collect is just who's being hospitalized. That's it. And that's actually a pretty simple data element. All of the other data is kind of icing on the cake. The most important data element is just who's in the hospital, when did they leave, and where did they go. And that alone could drive a lot of the change within healthcare.
Are you seeing long-term changes?
We are, yeah. The RCT is about 150 patients in, so we're going to have to get to 800 patients for statistical significance. I think what you're going to see around the country are effect sizes somewhere between 15 and 25% reductions. Is most likely what you're going to see, is my guess. One of the things you need to be very wary of is when vendors bring you pre and post data. If you take 100 high utilizers and do nothing with them, 100 outliers in any system, and just leave them alone, they do something called regression of the mean. They drop by about 30 to 40% just naturally on their own. In other words, if the patient that went 450 times just gets a little tired, it's hard to go 450 times in a year. The next year you go 350. Well, that's like a 20% drop, you know. So the disease management vendors that are coming and selling their stuff to you are showing you these beautiful pre-post slides. Buy our product, your utilization in the state will go from this to this. And what you need to say is, do you have a randomized controlled trial to prove that? Because whenever they're tested in randomized controlled trials, they often drive costs up. So most of your states, the Medicaid HMOs, if you're an HMO state, their primary model of doing the work we do is telephonic case management. They hire nurses in cubicles calling homeless people with no phones. So in New Jersey, they have 720 FTEs of nurses in cubicles, spending $38 million a year. You could have my model all over the state of New Jersey. So, once again, it's sort of an example of sort of the obsolete service delivery models that are going on. The randomized controlled trial models on telephonic case management, they just don't work. I mean, poor people get called by bill collectors. When the next call comes in from the nurse saying, did you take your medicine? I mean, I have a hard time shifting their behavior right in front of me when I'm in my office. The idea that a nurse in a cubicle in an office tower from a health plan is going to shift behavior in a poor community just defies logic. Even the phone numbers change so often you can't even find people.
I'm amazed that these managed care organizations aren't using your model, because it seems like it would save them so much money.
They're beginning to, but let me tell you another perversity in the system, is that the way your states pay them and CMS approves them to be paid is a cost-based reimbursement model. So if their costs go up, their reimbursements go up. The insurance company model is this giant bucket of money that you invest in the stock market or buy bonds, and your only goal is to make sure that the money coming in and money going out is coming in and out at the right pace. And you want to sit on a big bucket for as long as you can. And you make a lot of money on that model. So each year they're going to do a look back in the claims data, and if the cost trends have been up, then they're going to set the increase to 3%, 4% from the following year. Suddenly the cost trends went down, there'd be panic, like, oh, the bucket's getting smaller. Their profit model is a tax on the bucket. The bigger the bucket, the bigger the profits, and it's a pretty simple business model. I had an HMO say to me in New Jersey, if we adopted your model and you saved money, they would just take it out of our rates the next year. We'll lose money in your model. They've been writing these folks off for 30 years. They're just like accepted losses. It's an arbitrage model, really. So that's why legislators, you guys, are going to just have to stomp your feet and say we've had enough. Now, to their credit, there's a lot of change going on in the insurance industry. They realize that if they don't deliver value, their model's going to go away. So there have been some really sophisticated stuff going on now in the insurance industry. We have a great project we're doing together with United Healthcare. They have been incredibly good allies. We're now working with our Blue Cross plan as well. They're both making upfront payments, and we have citywide shared savings. So they've essentially said to us, instead of working with each office individually, we're now going to work with you as a group and do quality improvement projects and service delivery projects together. So there's a big sea change going on in the healthcare industry. They're making lots of progress. They're beginning to rethink this. But even the way they're paid is going to have to change as well.
We thank Dr. Brenner for his...
Great. Thank you.